Welcome again to another pediatric lesson, everyone. In this lesson, I will discuss about dermatologic disease of the neonate, especially the most common one. Functionally, neonatal skin is predisposed to greater heat and fluid loss, as well as drug and toxin absorption. Structurally, this immaturity often results in understated, atypical, and ambiguous skin symptoms and signs. Common morphologies of neonatal skin disease include pustules, vesicles, and bullae, dry, red, and scaly skin, and also less commonly ecchymosis and crustes. Although many common dermatoses are transient reactions to hormonal and environmental factors such as heat and trauma, infection by bacteria, viruses, and fungus can cause both morbidity and mortality. Neonatal skin is usually soft and smooth, covered with vernix cages, a derivative of sebaceous secretion and decomposing epidermal cells. Desquamation is usually delayed, occurring between 24 hours and 3 weeks, earlier in term than preterm babies. Desquamation on day 1 might represent intrauterine anoxia or a disorder of keratinization, such as ichthyosis. Curl usually rapidly becomes pink apart from the hands, feet, and the lips, where initial dusky acrocyanosis may occur as a result of increased vascular tone. To start from the most common benign skin disorders, the first one is sebaceous hyperplasia. Minute, profuse, yellow-white papules are frequently found on the forehead, nose, upper lip, and the cheeks of term infantis, and they represent hyperplastic sebaceous glands. These tiny papules diminish gradually in size and disappear entirely within the first weeks of life, and no treatment is required. The second one is milia. Milia are superficial epidermal inclusion cysts that contain laminated keratinized material. The lesion is a firm cyst, 1 to 2 mm in diameter and pearly opalescent white as you see on the image. Milia may occur at any age, but in neonates, they are most frequently scattered over the face and the gingiva and on the midline of the palate, where they are called epstein pearls. Milia exfoliate spontaneously in most infants and can be ignored, and no treatment is required. The third one is sucking blister. As you see on the image, solitary or scattered superficial bullae present at birth on the upper lips of infants are presumably induced by vigorous sucking on the affected part in utero. Common sites are the radial aspect of the forearm, thumb, and index finger. This bullae resolves rapidly without sequelae, and they may occur in conjunction with sucking pads or calluses, which are found on the lips and are a result of combined intracellular edema and hyperkeratosis. The fourth one is cutis marmorata. When a newborn infant is exposed to low environmental temperature, an evanescent, lacy, reticulated red and bullae cutaneous vascular pattern appears over most of the body surface. This vascular change represents an accentuated physiologic vasomotor response that disappears with increasing age, although it is sometimes discriminately even in older children. And in this case, it's also a benign condition and no treatment is needed. But if the child is hypothermic, rewarming is needed. Cutis marmorata telangiectasia congenita, which is present in a familiar fashion as that of cutis marmorata, but is a vascular anomaly in which the lesions are more intense, may it be segmental and rarely may present despite warming of an infant. They might be associated with loss of dermal tissue, epidermal atrophy, and ulceration. The lower extremity are usually affected in the case of cutis marmorata telangiectasia congenita, with limb atrophy noted on the affected side. Gradual fading of leafed erythema occurs over 3 to 5 years, but limb asymmetry is permanent. Extracutaneous findings such as ocular, neurologic abnormalities may be associated in 20 to 80% of cases. And also in this case, there is no specific treatment needed. The fifth one is NEVUS simplex or SALMON patch. As you see on an image, NEVUS simplex is a small, pale pink, ill-defined vascular macule that occurs most commonly on the glabella, eyelids, upper lip, and a nuchal area of 30 to 40% of normal newborn infantes. These lesions persist for several months and might become more visible during crying or change in environmental temperature. Most lesions on the face eventually fade and disappear completely, although lesions occupying the entire central forehead often do not. Those on the posterior neck and occipital areas usually persist, and treatment is not usually indicated, though pulsed day laser treatment can be helpful in lightening lesions that are persistent and cosmetically bothersome. Nevus simplex should not be confused with a port wine stain, which is a capillary malformation which is permanent lesion and it might be associated with Sturge-Weber syndrome. Nevus simplex is usually symmetric with lesions on the both eyelids or on both sides of the midline, whereas port wine stain are often larger and unilateral and they usually end along the midline. The other benign skin disorder of newborn is Mongolian spot or dermal melanocytosis. Dermal melanocytosis, which appears as blue or slate gray macular lesion, has variable defined margins. As you see on the image, it occurs most commonly in the sacral area, but might be found over the posterior thighs, legs, back, and the shoulders. The spots might be solitary or numerous and often involve large areas. This is a result of dermal location of melanin-containing melanocytes or mid-dermal melanocytosis that are presumably arrested in their migration from neural crest to epidermis. They usually fade during the first few years of life as a result of darkening of the overlying skin. If lesion persists, they might be treated with lasers if desired, otherwise no treatment is required. Some people are complaining about the fear of malignant degeneration, but malignant degeneration does not occur. The other benign skin disorder of newborn is erythema toxicum. As you see on image, a benign self-limited evanescent eruption, erythema toxicum occurs in approximately 50% of full-term infantes and it is relatively less common in preterm infantes. The lesions are firm, yellow-white, 1 to 2 mm papules or pustules with a surrounding erythematous flare. At times, blotchy erythema is the only manifestation. Lesions might be sparse or numerous and either clustered in several sites or widely dispersed over much of body surface. The palms and the soles are usually spared in the case of erythema toxicum, and the peak incidence occurs on the second day of life, but new lesions might occur or erupt during the first few days as the rash waxes and wanes. Onset might occasionally be delayed for a few days to weeks in premature infantes. Eosinophils can be demonstrated in right-stained smears of intralesional contents. Otherwise, cultures are sterile. The cause of erythema toxicum is unknown, and the lesions can mimic pyoderma, candidiasis, herpes infections, and other neonatal conditions such as malaria, but can be differentiated by the characteristic infiltrate of eosinophils and the absence of organism on stained smear. The course is brief, mainly 3 to 7 days, and the lesions generally resolve without pigmentation. No therapy is required at all, and the lesion subsides within few days of life. The other is transient neonatal pustular melanosis. Pustular melanosis is a transient, benign self-limited dermatosis of unknown etiology that is characterized by three types of lesion. Evanescent superficial pustules appear first, and this is followed by ruptured pustules with a collaterate of fine scale, at times with central hyperpigmented macules, and finally hyperpigmented macules are persistent for few months. Lesions are present at birth, and one or all types of lesions might be found in a profuse or sparse distribution. As I have said, pustules represent the early phase of the disorder and the macules are the late phase. And the pustules phase rarely lasts more than 2 to 3 days, whereas hyperpigmented macules may persist for as long as 3 months. The sites of predilection are the anterior neck, forehead, lower back, although the scalp, trunk, limbs, palms, and the soles might be affected. The active phase shows an intracorneal or subcorneal pustule filled with polymorphonicular leukocytes and debris. whereas in the case of erythematoxima, it is eosinophils. The macules are characterized only by increased melanization of epidermal cells, and the cultures and the smears do not contain bacteria or dense aggregates of eosinophils. No therapy is required in the case of transient neonatal pustular melanosis because, as its name indicates, it is a transient condition. The last one is hair-looking color change, a dramatic vascular event. Hair-looking color change occurs transiently in up to 10% of newborns, most commonly on the days 2 to 52 days of life. It probably reflects an imbalance in autonomic vascular mechanism, and when an infant is placed on one side, the body is bisected longitudinally into a pale upper half and a deep red dependent half. As you see on the image, the color change lasts only for a few minutes and occasionally affects only a portion of trunk or face, and changing the infant's position may reverse the pattern. Muscular activity causes generalized flashing and obliterates the color differential. Repeated episodes may occur, but it does not indicate permanent autonomic imbalance. There is generally no need for treatment in the case of hair-looking color change, but we should have to differentiate hair-looking color change from hair-looking syndrome, which is associated with paroxysmal hemifacial flashing and sweating with or without Horner syndrome. And in the case of hair-looking syndrome, unlike that of hair-looking color change, symptoms are induced by heat, stress, or exercise, and some cases are secondary to trauma, cervical cord cernix, and some might be due to neuroblastoma. And also hair-looking syndromes are mainly occur in older children, although rarely it might occur congenitally. So this is all about the most common benign neonatal skin disorder. Thank you for watching.